all for joining us today for our, I reckon this now is our fifth or sixth, for Thursday education event. I've got two people on today. I've got Jamie Mitchell, who's going to talk to us around green general practice and things that we can do inside of general practice to make things a little greener. But kicking off is Jonny Bewick. We've tried to get Jonny on a number of times, so this is really good that we've managed to get you in. And Jonny's going to talk to us about how we can manage chronic pain inside of primary care. A couple of things you can do here if you want to put questions into the chat, and Jonny pick them up at the end, or we normally just say last 10 minutes after his presentation to pick up any questions, or if Jonny doesn't mind people getting interrupted, it's entirely up to them. Right, without further ado, thanks very much, Jonny. I'll let you go and I'll go be quiet now.
Lovely. Thanks for the introduction, Michael. And yeah, I'm sorry that it's taken a little while to get this organised. That's completely my fault. So I'm going to start off with a bit of a disclaimer, if that's okay. So I'm a GP who works in Cramlington at the Village Surgery. I've certainly got an interest in chronic pain, hence the reason for doing the talk this afternoon. But by no means am I an expert. So the reason that I'm doing the talk is that during my GP training, I did an ITP in chronic pain management. And then on the back of that, I was lucky enough to get a place on the fellowship scheme and did a diploma in pain management for that. And more latterly have been involved with Graham Sayers, GP up in Alnwick, who's starting to develop a regional pain network. So yeah, the first couple of plugs are about that regional pain network, just to keep an eye open for things that might be cropping up. And the second thing is with regards to the GP fellowship scheme in Northumberland, which I'm still involved with Dr. Orla Collins. So if anyone wants any more information about that, I've put my email address at the end of this presentation. I'm happy to take any questions about that as well. So what we're going to try and cover today, I appreciate that sort of chronic pain is a big subject, and in 30 minutes just probably only going to really scratch the surface. So what I'm hoping to cover this afternoon is a bit of what is chronic pain, why it's important, and a bit of a hot topic at the moment, with some information around recent QOF targets, some thoughts about assessment and management, and then share some useful resources which I'll send to Michael to be distributed at the end of the session as well. So if we start off with what is pain. So in 2020, the International Association of Pain revised their definition to describe pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in such terms, which was the previous definition from 1979. So the focus from the revised definition was really a shift away from the focus on description, and also the fact that pain isn't subjective, so we didn't want it to be interpreted as being imagined or not real. The purpose really of the revised definition was to hopefully lead to a change in the way that pain is both assessed and then consequently managed. So along with the revised definition, they also came up with 6 keynotes. So the first of those is that pain is always a personal experience that's influenced to varying degrees by biological, psychological, and social factors. The second keynote was that pain and nociception are different phenomenon. So the idea that pain cannot be inferred solely from activity in sensory neurons. The third was that through their life experiences, individuals learn the concept of pain, and that's important when we think about different cultures, different cultural differences, and their attitudes towards pain. The fourth, I beg your pardon, was that a person's report of an experience of pain should be respected. The fifth, although pain usually serves an adaptive role, it can have adverse effects, and that includes adverse effects on things like function, on social interaction, and it can have a detriment on psychological well-being, which is something we'll touch on a little bit later. And the final note that it said is that verbal description is only one of several behaviours to express pain. So in other words, an inability to communicate doesn't mean that someone is not suffering with pain. And that was one of the shifts with the revised definition that came out in 2020. So as I'd mentioned, pain is multifactorial, consists of biological, psychological, and social factors. And all of these combined contribute to the pain syndrome. And the thing that makes pain chronic is its duration. So in other words, pain that is persistent for more than 3 months. And in particular, that's pain that's become independent of the underlying injury or illness that started it all. And that can be quite key when you're trying to explain that to patients. So I'm just going to touch very briefly on some sort of pathophysiology. I don't mean to bore you, but physiology of pain consists of 4 different stages. That is transduction, so nociceptive stimuli, which usually indicate a potential for tissue damage, are converted into action potentials. The second stage is transmission, where these action potentials are transmitted along the neuron to the dorsal horn of the spinal cord. The third is modulation. So action potentials get coded via an excitatory or an inhibitory pathway. And then the final stage is perception. So the perception of pain is generated by affective, autonomic, behavioral, or cognitive responses. And as we said, that usually serves a protective purpose. So in just to introduce a couple of concepts, central sensitization and wind-up phenomena, I'll just touch on these briefly. So the diagram in front of you should show sort of the normal pathways. So noxious stimuli is transmitted along a nociceptor and is perceived as pain. Then you've got sort of light touch, which is passed across a low threshold mechanoreceptor. The idea is that sort of following injury like a cut or a bruise, touching the injured area would be more painful, so it results in us protecting that area. And that process is known as hyperalgesia, and it's usually due to a previous painful stimulus associated with tissue damage. And that can have consequences and changes in the neuronal sensitivity, which is known as sensitization. So with that in mind, central sensitization, there's disruption of those pathways. So essentially, the clinical presentation of central sensitization is one of 2 things. One is hyperalgesia. So that describes increased pain from a stimulus that normally provokes pain. And the second is allodynia. So whereas something that wouldn't usually cause a painful stimulus, so the diagram shows a touch of a feather, that can provoke a painful reaction. So in other words, the stimulus leads to an unexpectedly painful response. The sensitization can be defined as the wind-up process that occurs in the nervous system, and I think that that's one of the things that is quite important when you're trying to explain the different changes between acute pain and chronic pain when it comes to managing patients' expectations. So the wind-up phenomenon is a short-lived process of increasing pain intensity, and over a period of time, exposure causes an exaggerated response, even with a relatively innocuous stimuli. For what it's worth, that's mainly from peripheral nerve fibers, which send electrical impulses. And the process of wind-up pain is progressive in firing wide dynamic range neurons with repeated stimulus. And these repetitive stimuli can sometimes contribute to long-term pain. Grand. So why do we discuss chronic pain and why is it a bit of a hot topic at the moment? Well, the first thing is it's quite common. So the prevalence of significant persistent pain is around 23%, and that increases with age, affecting up to around 30% of older adults. The prevalence of chronic primary pain is unknown in England, but the suggestion is that it's anywhere between 1% and 6% of the population. And the 3 most common types of pain that we tend to encounter are back pain, headache, and joint pain. Chronic pain also comes with complications, so disability, especially if it's poorly controlled. Chronic pain can lead to significant disability, psychological distress, which is quite a common thing that we see, particularly things like anxiety and depression. Medicines misuse, which is a real hot topic at the moment, and particular risk of dependence and withdrawal. So that can occur in sort of 25 to 30% of the population who are suffering with chronic pain taking opioid medication. There can be an impact on sleep and then adverse side effects from the various different medications, which we'll talk about in a little bit. The prescribing issues that we're facing at the moment. So 1 in 4 people in England are taking prescription medications with the potential for dependence and withdrawal. These include things like opioids, sleeping tablets, gabapentinoids, and antidepressants. And if we break those numbers down a little bit more, the proportion of the adult population prescribed each of these class of drugs, so antidepressants is around 17% of the adult population, Opioids around 13%, gabapentinoids 3%, benzos 3%, and then Z drugs like zopiclone 2%. So the 2% on the face of it looks relatively small, but when you think about the population of England, which this is referring to, that's over 1 million people, and the opioids, it's about 5.5 million. So the prescribing rates for opioids and gabapentinoids are strongly linked to areas of socio-economic deprivation, and there's higher rates of prescribing in women and older adults, which is important when we think about the side effects of these types of medications. The prescriptions for antidepressants and gabapentinoids are still increasing, but thankfully the prescriptions for opioids and benzos are starting to head down. Again, sort of to put it into some kind of context, the gabapentinoid prescribing showed a 10-fold increase between the years 2000 and 2015. And most of that was off-label use with sort of little evidence for the effectiveness. And that's consequently created a bit of a problem around dependence. So as I mentioned earlier, there's a bit of a QOF update that's come in. So this is the message that had come down with regards to the QOF and the quality improvement project. So the hope is that use of non-pharmacological alternatives rather than initiation of DFMs, dependence form of medications, would be done in line with best evidence and guidance. We should be doing structured medication reviews of patients taking over 120 milligrams of oral morphine equivalent, and especially when there's polypharmacy or inappropriate use. So the outcomes from that quality improvement project are supposed to be reduced initiation of the prescribing of medicines, reduced duration of courses that may cause dependence if used for a longer period of time, increased risk of non-pharmacological support and interventions with improved patient understanding of potential benefits and consequently, or as much as that harm, and options to enable for people to make informed decisions with sort of non-initiation of the other drugs like ketamine, quetiapine. So these are the steps that were sort of suggested that practices should be following. However, we've still got a lot of work to do. So these are some slides that Graham Sayers, one of the GPs up at ANIC, has kindly shared with me. So NENC is North East and North Cumbria, and we are the red line sort of within that ICB. And as you can see from that, we're above the national average. That's for all opioid prescribing. And despite a lot of work that's been done locally, we're still above on those high dose opiates. So those who are over 120 milligrams of oral morphine equivalent. So still quite a bit of work to do. So just a couple of thoughts on how we can potentially achieve better outcomes for those people with chronic pain. One is through assessment. So good communication is really key to understand the patient's experience, giving them the time to sort of tell their story, if you like. Should be checking about a patient's understanding of what the cause of their pain is, their acceptance of it, and then their expectations, which need to be managed quite carefully. It's important to validate the patient's experience of pain and to provide them with sort of ongoing support. That's something that I'll touch on, but utilising other members of staff in the practice, so things like the pharmacists, which we've had involved within our PCN, and the medicines technicians as well, have been a great source of support. We should, when we do communicate, try and do it sensitively and try and be open and honest with patients and acknowledge that pain actually might not improve over time and actually can get worse as well. And with that in mind, setting realistic expectations. So something that we've sort of tried to set up locally within our PCN, and particularly within the practice that I'm at the moment, is the idea of a pain clinic. So giving people slightly longer appointment times so that they can go through all of this rather than feeling rushed and trying to do it in between firefighting and doing various other jobs. We've also found that it's been much better to do these kind of appointments face to face rather than telephone, because I think that patients get a lot more out of it. And especially appreciating sort of impact on their life outside of pain. So the physical impact, the psychological impact, which we've already talked about very briefly. So some of the key recommendations that NICE came out with a couple of years ago is that patients should receive personalised, holistic care based on good communication and a collaborative, supportive relationship between the patient and the health professional. As we've talked about, it's important to be open and honest, and also to be sensitive and not invalidate any of the patient's pain experience. So with that in mind, again, sort of discussing the likelihood that symptoms can fluctuate over time and that they can have flare-ups, and the possibility that a reason for the pain might not necessarily always be identified, the possibility that the pain may not improve or, as we said, can get worse over time despite ongoing management. And even if pain were to sort of stay the same or deteriorate, that doesn't mean that we can't manage things so that someone's quality of life isn't as severely affected. So the sort of party line coming down from NICE is that patients should not be prescribed paracetamol, non-steroidals, benzodiazepines, or opioids for chronic primary pain. And that's even for short-term use. So there's little or no evidence that they improve pain or improve psychological distress or quality of life, and no evidence really for longer-term use because of the harm that can be associated. However, NICE added a nice little caveat where if patients are already taking those kind of drugs and are experiencing benefit from them, it's appropriate to sort of explain the risks, go through some education with them, and potentially continue them with a shared agreement, which can be quite difficult when we're thinking about de-prescribing, which is obviously something that a lot of people are getting involved with at the moment. So NICE also suggests that there is a role for antidepressants. So consider an antidepressant, either amitriptyline, citalopram, duloxetine, fluoxetine, paroxetine, or sertraline for people over the age of 18. And over a full discussion about the sort of potential risks and benefits. So if an antidepressant is offered to manage chronic primary pain, it's important, I think, to explain that this is because the medication can help with the quality of life, even in the absence of a diagnosis of depression. So it can improve things like the pain itself, but impact positively on sleep and also on psychological distress. But most of the evidence that's available is related to female patients who have a diagnosis of fibromyalgia. That's where a lot of the studies have been done. And duloxetine is the only one of those options that's currently licensed for chronic primary pain. So NICE also suggests that we should be thinking about some non-pharmacological treatments. So things with evidence include acupuncture, supervised group exercise programs, CBT, ACT, and that we should not be offering things like TENS or ultrasound because of little evidence. So again, whilst I think that it's nice to have those options, I think realistically accessing them is an issue, not just in our patch, but across the country. But always worth sort of bearing these things in mind, and patients are able to sort of arrange this kind of stuff privately as well if they're interested in doing so. So just moving on to talk about a couple of practical tips. So whenever we are initiating these dependence form of medications, all patients should be started on the lowest dose effective, and we should be thinking about using them for the shortest possible time. We should be providing written information, especially when prescribing opiates acutely, so that people are aware of the longer term sort of dangers of using that medication. And again, one of the things that we've tried doing is using AccuRx to sort of share some resources with people. But there's various different things and some resources that I've included at the end that people might find useful. All of these patients should be having a regular review after the dependence form of medication is initiated, and particularly important is the 3-month stage where that pain would be considered to be chronic. So at that point, that's where we really should be discussing the longer term risks of continuing medication. The other important thing, which obviously makes sense, is that if there's not been any response, the medication should be stopped, not continued. So 5 practical steps for reducing the higher dose opioids. These are from the Oxford Pain Management Centre. So one is education, explaining the importance of reducing opiates to the patient. Engagement, giving them as much choice as possible around how they're going to reduce their opioids. affecting the weaning plan and sort of making sure that everyone is aware that that's the plan that the patient has agreed to, and that's what we're trying to stick to. And especially in the current climate where people tend to not necessarily have the continuity with some person or the same clinician. The fourth thing is that we should recognise the emotional impact, so trying to manage concurrent anxiety and depression, which exists in at least 50% of those who've got chronic pain. And finally, trying to manage expectations, so ensuring that patients understand that the process can be difficult and that they're very likely to need support during that process, and trying to normalise that. So one of the resources that I've come across, which is quite useful, is the taken from the Somerset CCG, and it's codeine tapering. And again, like I said, I'm more than happy to share these resources at the end, but just a bit of a schedule that I've found useful when sort of dealing with people who've been on higher dose codeine, for example. There are similar schedules for tramadol and also the gabapentinoids, and again, I'm happy to share them when we finish the talk today. So some key information about opioid medications, which again I think is important to share with patients. They are and can be really good for acute and malignant pain, especially pain at the end of life. A small proportion of people do get benefit from them longer term, but that's more likely if they're used at a lower dose and if they use it intermittent rather than continuous. There's loads of evidence available, and it's been shared quite widely that the risk of harm increases significantly if people are taking more than 120 milligrams per day of oral morphine equivalent. And as we talked about the cough earlier, that we should really be targeting these people to try and reduce their opiate safely. If pain remains severe despite opiate treatment, then it would suggest that it's not working, and in those kind of instances, it should be stopped. And the other point that that should be made is that chronic pain is very complex. People can have refractory and disabling symptoms, particularly if they're on the higher doses. And we should be thinking about these people in particular, doing a very detailed assessment and thinking about emotional influences and how their pain experience is sort of affecting them. So these are various resources that I've come across over the last couple of years that I've found to be quite helpful. So some that are helpful for clinicians, others that can be quite helpful for patients, including some videos which you may have come across before. And also some practical advice there, which is around sort of managing stress and troublesome thoughts and feelings. So in summary to what we've talked about, I think it's important to allow adequate time. Like I said, one of the things that we've tried to do is increase the appointment time for these kind of people who are taking a particularly higher dose of the dependence form of medications when we're thinking about trying to reduce them and coming up with a shared plan for a strategy. I think it's important to provide information not only when we're initiating these medications, but also when we're talking about reducing or changing medications, and if people have made a decision that they want to continue, I think it's another good opportunity to provide them with all of the information. Easier said than done, but we should be aiming for continuity of care so that we're reducing the different contacts that people have where they might not be getting the same message. And again, one of the things that we've tried to do is utilise other members of staff within the practice, so the pharmacy team in particular, to try and help with that. Goes without saying, but we should be trying to avoid these dependence form of medications where possible, and it's really important to stop them if they're not effective. And finally, just to consider gradual de-escalation of medication with regular reviews and providing that support as we go through. Right, so I appreciate I've probably overran a little bit there. I do apologise. If there's any questions in the chat, I'll try and get through them when I hand over to Jamie, but I've also put my email address on there, jbewick@nhs.net. More than happy for people to sort of send me any questions, and whether that's about this or the fellowship scheme, more than happy to try and get back to you. Thank you.
So there's no questions have come into the chat. Don't mind. In fact, Jamie's rubbing his hands that he doesn't have to go as long if you can spend another 5 or 10 minutes. Is there any, happy to open it up to the floor? Oh, Grim. So what's really nice, I've just had a check down through the attendees today, and there's a load of new faces along here. So this is really good, but I'd like to start with, I think it was Graham. Do you want to fire away, Graham?
Hi. Yeah, thank you. Cheers, Jonny. That was really, really informative and very well presented. Thank you. One of the things that I've talked to patients about is how their medication can cause that hyperalgesia syndrome, and certainly opiates, we know. Do you have a way of kind of assessing whether that's happening in the particular patient's instances? Is there any sort of things that you've gleaned that give us an idea that hyperalgesia syndrome has occurred?
Thanks, Graham. That's, yeah, really valid point about the opiates in particular sort of contributing to that. Again, I think a lot of it is around sort of going back and making sure that you give the patient that time to have that thorough assessment at the start. And I think a lot of it is those kind of symptoms that you would associate with the hyperalgesia. So when people are reporting that certain things are causing or contributing to a flare of the pain that you wouldn't necessarily expect. And yeah, you're absolutely right. Actually, your medication could be making this worse rather than better. And I think that helps people engage a lot more if you're thinking about doing some kind of reduction.
Yeah, thank you.
Thank you. Yeah, so I'll go back to the resources, I beg your pardon, but like I said, I'm more than happy to share these around with people. So that's the resources for clinicians in primary care, which I found helpful. By no means is it an extensive list. There's lots of different things that are available. Most of these are actually free to access as well, which I've found quite helpful. Some of the ones for pain, and then some videos that I found quite useful as well.
Oh, that's great. So, Jonny, what I'll do is I will we'll put this presentation up onto our channel. I'm going to share this in the training book as well, especially those additional videos, because it is something that we get asked about a lot, and obviously there is a lot of pressure on us to kind of fall in behind those nice guidelines and reduce prescribing of those, as you say, dependent drugs. So that's really useful. If there's no more questions, then I will release you, Jonny, and I'm going to stop recording, and then I'll bring